going to go ahead and get started.
Can you hear me?
Mark, your music to our ears.
Can you hear me and see me?
We can see you just fine, and we can hear you just fine as well. Thank you for joining us. Let me.
Oh no, this is a pleasure. Believe me. Sorry, I'm a couple minutes late. It's just a long story.
Well, let me just make a few introductory comments. This is Norm Ward. I'm the Chief Medical Officer for OneCare Vermont, and we have a large group on the phone today. This is coincidentally the kickoff presentation for our learning collaborative, our Asthma COPD learning collaborative, which is sponsored by several organizations who are going to be letting themselves be known to all of you in a little bit. But our kickoff presentation today is by Dr. Levine, Commissioner of Health. After his presentation, those entities who are participating in the Learning Collaborative will have a chance to meet between 3 and 3:30. You're just basically going to stay on the line on this particular WebEx. Tanya has the ability of muting everyone, and if there's a moment where even Dr. Levine gets muted, Mark, you may need to unmute yourself so that you can be the only speaker if we run into troubles with extraneous noise. Mark has a lot of content today, and we may or may not have time for questions within the hour. Please, by all means, put your questions into the chat box, and most of those questions, we will lean on him to do so. But then if there are some other questions that are of, excellent quality, we'll try to get some written responses back to the participants on the call today. Tanya, next slide, I think. Well, I'm certainly not going to take 15 minutes. And I think that Mark goes without any introduction. I mean, he's become a celebrity in the state. He's had more media time in the last several months than most TV personalities. And I can't think of anybody that has handled themselves with more class and professionalism over these several months. So, my biggest connection to Mark is his years and years of dedication to educating, I'll say generations of medical students and residents at the medical center. And I think he has our unbridled respect. So we're going to kick off trying to understand how COVID-19 impacted our two target illnesses of asthma and COPD. This is good for CME credit for you. And I think we're about ready to start, unless Tanya puts a slide that's going to surprise me. There you go. This looks like Mark's first slide. Thanks again, Mark.
Thank you, Norm. I appear to be unmuted, so if I'm not, tell me. So my goal is to go 30-ish plus minutes, so I hope I can leave time for questions. It'll be important because that part to me is the most important part. Let me just get a drink of water. My goals are to lead you a little bit through the pandemic first, to weave in the respiratory diseases, but also weave in a health equity message as well, because that dovetails nicely with the focus on the respiratory illnesses. And I think I was kind of charged with doing all those three things anyways, updating you on the pandemic and doing everything else. So it looks to me like Tanya or someone is going to regulate the slides, which should be pretty self-explanatory as we move along. Everybody knows that as we got into COVID-19, it was not smooth sailing by any means. It was a huge challenge because even though today we don't have a national response, then we didn't either. and it was a very slow, and I'm calling it inept. I'm being critical, but I don't think there'll be a lot of disagreement with that. Plus, we were dealing with a virus that we'd never seen before and that humans had not been infected with before. We had a huge opportunity with travel, but it became a huge risk because we kind of still let everybody come through the airports of the country, bringing in the virus with them to exceedingly high levels. And the fundamental rule of Public Health 101 is to contain infectious diseases. And you can't contain a disease you can't test for. So without testing capability, we couldn't pursue a policy of containment at all from the start, and not to mention the crisis in PPE that we've come out of now, but that we were in. Moving along, there were some fundamental components of our early response. So you could go to the next slide unless I have that ability. So we activated our Health Operations Center and State Emergency Operations Center way before we ever saw a case, because we really did pursue this with a sense of urgency. We had some world experiences to learn from, and we didn't want to be caught short by any means. Early on, recognizing there was community spread was critical, because once community spread has begun, you begin to get into that exponential growth phase where you get into deep trouble so quickly that you didn't even blink an eye. Secondly, we didn't have a lot of work that was preceding this pandemic. We had a playbook from the CDC about the flu published 3 years ago. So we utilized that, but there wasn't a lot of other, like, here's the how to manage a pandemic in the state of Vermont. We knew, as I said, that containment wouldn't work. We looked at the epi curve, which I'll show you in a second. We, in a phased, progressive fashion, introduced community mitigation strategies, the so-called NPIs, non-pharmaceutical interventions, the things you have to fall back on when you can't contain the virus. And then, thank God, we have a governor whose first priority is always health and safety. And he thinks if he does nothing else right, if he doesn't get those two things right, kick him out. And he believes in the science, believes in the data, and listens to his health colleagues. So I've got the graph on the next slide that really illustrates what everybody remembers about flattening the curve. But suffice it to say that as you're going on the ascending limb on that red curve, that's exponential growth of the virus. So for the beginning, we were in that little bit of a tail in the beginning of the red that wasn't so steep. But once we knew it was going to that steep part, it was very easy to figure out what to do and how quickly to do it. Because if you don't, you end up on the red curve and you have no chance to be on the blue curve at all. And your healthcare system totally falls apart because too many people are hospitalized and requiring ventilators, etc. Moving again along, a few milestones just to put us in perspective. First case, March 7th. 4 days later, second case. 12 days after the first case, the first death. 2 weeks after the first case, our outbreak in Burlington Health and Rehab. And then all of a sudden, less than a month later, we had our peak of cases, and we've never been that high again.
Impact on those with respiratory conditions.
On the next slide, we talk about the mitigation strategies in terms of the milestones. So 6 days after the first case, we instituted a state of emergency with restrictive visitation policies. Very shortly thereafter, progressive decreases in mass gathering sizes and they happened with increasing frequency to get to very low sizes. The bars and restaurants were closed just a few days after the state of emergency. We took a little extra time on the schools, but after a weekend where we didn't just sleep on it, we looked at the data every day, and the data looked like, oh my God, this is happening. It was quite clear that schools were not going to reopen on that Monday. We gave them a couple days so that they could put it all together. And then again, on the 21st, we closed the close contact professions, gyms, barbers, etc. And then stay home, stay safe is literally 2 weeks after the first case came to Vermont. That's how fast things moved. Moving on to the next slide, you'll get a real idea of why I think, at least my view of the world, why Vermont has enjoyed the success it had in the low incidence rate, low death rate, and low percent positivity. I have to give credit to Vermonters first and foremost, because without a population that actually are believers and listen to you and prioritize health, and there are states where none of this happens, you can't succeed. There's a reason Vermont always ranks in the top 5, whether it's the Commonwealth Fund, the United Fund, or some other rater of a state's overall health. It's because Vermonters are interested in that and they prioritize that. So clearly that helped in this epidemic response. We early on addressed the issue of protecting the most vulnerable, and we learned our lessons hard with Burlington Health and Rehab and then Birchwood, but thank God none since then. But protecting the most vulnerable means early on restricting visitation policies, of course, which are very harsh.
My trick, Dan.
In addition, they involve helping protect the nursing home from the biggest threat, which is their staff who live in the community, of course, and their new admissions, which may come from the hospital, may come from another state. And that's probably how our 2 worst case scenarios occurred, from admissions from other places. So a lot of policies around protecting them with quarantines and redundant testing protocols, etc. We never reopened the state until there was a sufficient level of virus suppression, quite a sufficient level, I should add. And then we pursued not just let's open everything and go straight to the bars, like many states in the South have done, but we did a very phased and gradual reopening. We, meaning the governor, myself, but really the whole team, are considered trusted messengers and trusted resource, which of course the national administration doesn't enjoy so much, and we get compared to that frequently. But state to state, that's a very variable equation. So it's really important that that be present. And then being able to teach people about contact science, which to me is just the 3 contact principles. One-to-one contact obviously is highly dangerous in a state where there's a lot of virus around. Contact density is not always so good. That means being in a crowded room, and God forbid you're in a crowd indoors as opposed to outdoors. And then contact intensity, the duration of contact. And indeed, we use that when we do contact tracing every day now, because we've kind of messaged to people that if you were in contact with someone who had COVID, it could have been like you were in the same building as them. Well, you probably don't have to quarantine yourself. But if you were in close contact, less than 6 feet for more than 15 minutes, you are going to quarantine. So just those principles alone are important. And then finally, in this introductory phase of the presentation, the lessons we've learned. And if you can move to the next slide. Everybody now understands, though not all believe in, the importance of asymptomatic spread. The CDC created some new controversy about that, you recall a week or 2 ago, when they said, test symptomatic people, but you don't have to test everybody who's been in contact with someone with COVID. But the reality is, if you're going to quarantine somebody, you can test that person and then do contact tracing on the people that they've been in contact with if they become a positive test. So very important. Validation of simplified guidance, that's just the 4 rules of stay home when you're sick, wash your hands, stay physically distanced, and wear masks. Containment works, that basically is the box it in strategy, though I'm told that if you say the words box it in, there are some underprivileged populations that actually feel like you're threatening them. So we try to avoid saying that, but it's testing, isolating those who test positive, contact tracing all those that you've isolated, and quarantining those that are important to quarantine based on their exposure history. Simple, 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 takes professionals to do, takes a workforce to do, and takes real capacity to do testing, which means not only testing symptomatics, but testing asymptomatics, testing people because you've targeted that population for a reason in terms of an outbreak or what have you, so very strategic testing, and then stockpiling, because early on, it wasn't uncommon to run out of a reagent, and then your whole testing enterprise is shot. So you really need to have a diverse portfolio of testing platforms and stockpiles, not to mention stockpiles of PPE. Another lesson about protecting the most vulnerable, which I've described to some degree, but extend that to other vulnerable populations like the prisons. The concept of health equity. Everyone here probably recalls we had a little outbreak in Winooski and Burlington. We, the health department, learned as much as anybody else about health equity then, and making sure everyone has the opportunity to be healthy and to hopefully not get the virus. But it turns out that you need to pay a lot of attention to interpretation, to having documents in multiple languages, having the proper community partners and collaborators like AALV and USCRI who are fundamental to working with those populations and are very trusted, responsible groups, et cetera, et cetera. Learning that reopening and risk can be balanced. So again, being very phased and progressive in the way we do things and doing it in a very targeted way where we're not going to start with the bars, we're going to start with things like outdoor retail. If you could move to the next slide. One thing that governors from states that wanted to just open quickly say is that, you know, we can't have it all ways. People are suffering too much economically. We need to reopen our state. And even though the public health enterprise is not advising us to do that, the hell with them, because this is more important. I think in Vermont, we've proven that you can have both the public's health and the economy's health in mind, and they can coexist, and you can open safely. Not as quickly as you might want, and that will prolong the economic suffering, but we would hope that government can step in to help with that. I've also learned that everything's potentially controversial. There are people who still think the pandemic is a hoax. There are people who really don't think the deaths are important because those are just old people who were sick and they were going to die anyways. There are people who really feel that the kids are very important vectors and they're going to really infect us all unwittingly, and how could we dare open schools? And there are people, of course, who, when they hear about flu vaccine, think we're going to make it mandatory for them to get that, as well as the eventual COVID vaccine. So had to be able to deal with a lot of issues that people come up with. And then finally, being a rural state is not protective. And we've learned that in this more second resurgent phase across the country, where states are having more trouble, not the Northeast, thank God. And the trouble is not necessarily in their metropolitan areas, it's in their rural areas. Okay. Having said that, I'll just show you some pictures, and we can go through these very, very quickly. This is just sort of the overall graph of our 1,637 cases over time, and you'll see that April 3rd peak, and then things came down nicely. Little peaks here and there from small outbreaks like Winooski, but bottom line is things have held relatively stable. The majority of the deaths were in the first third of the pandemic in Vermont. We've had scattered deaths since then. We haven't had a death now in about 45 days. And the one that we had 45 days ago, there had been over 50 days that went between that one. Next, this is just to show you that early epi curve with that steep, almost vertical upslope. And then we put everything into place, and now we've pretty much had a consistently sloped curve. Obviously, you don't eliminate new cases, but you eliminate that high peak slope that would overwhelm the healthcare system. Show you county by county, just incidents on the left and rates on the right. Predominantly Chittenden and the two southern counties, as you can see, are the the hotspots traditionally in Vermont. The bottom two mostly because of where they border more than anything else, and Chittenden because it's the most populous. And then if we look at Vermont compared to other states, we're that little red thing at the very bottom. We have like the lowest cumulative state case rate in the country, and we just went below Guam. Guam went above us. So that was another historic landmark that happened today, I believe. On the next slide, we'll look at the death rates, where we're also quite low when it comes to deaths. And the only things below us on there are Wyoming and Hawaii. And this is of September 1st, so we may have improved since then, because that's when I put the slide together. And then finally, our percent positivity rate, which is the red line. The bottom line is everything to the right of March is less than a couple percent. So we've gone anywhere from 0 to 11% over time. Our average percent positivity rate is 2%. With a 2% positivity rate, you can essentially reopen anything you want, but not all at once. Because if you do it all at once, you won't see that impact over the next 2 weeks to let you know if you need to slow down or not. The next slide just shows that we've done a hell of a lot of tests, and we can move on from there. The big steep part on the right is from college retesting, adding into our usual testing. And then the next slide just shows that common sense, the rate of disease is highest if you're in the oldest demographic, even though by numbers, there are more cases, obviously, in people who are from their 20s through their 50s. Females and males have similar rates. That's all I'm going to say on this slide. And then this slide will lead you to believe there's about a 27% rate of cases that are asymptomatic, and there's even more in the pediatric age group, as the bar graphs on the right demonstrate, with larger numbers of gold than magenta. But the bottom line is that's of cases. That's not even of people in the population. So if you add in people in the population who never got tested but are out there but have no symptoms and could be potentially infectious, you'd get higher than 27%. Okay. So most cases, as you're all aware, the healthcare system has not been overly stressed. If you look at 1,400 cases not hospitalized and 1/10 of those hospitalized, and then a handful that we don't actually know the result on, the minority of cases have been hospitalized. Today, we have one person in the whole state in the hospital and 3 people as PUIs. And when people did get hospitalized, they were sick. So 35% of them ended up in the ICU, and a number of those ended up on ventilators, though we never got even close to the number of ventilators we were worried about needing. If we move on to the next slide to look at deaths, obviously the rate of deaths is highest in the oldest age demographic, and many of those came from the 2 nursing homes, almost half. But death rate by race is actually very similar, and that's because we've had such a low death rate, if nothing else. The deaths that do occur, as the next slide shows, occur almost exclusively in the long-term care facilities or the hospitals, with hardly anybody dying at home or elsewhere. Next slide. Everybody has heard that if you're older or if you have other conditions, whether they be immunocompromising or just chronic diseases, you're more likely to get COVID. This is our Vermont experience. 55% had a pre-existing risk factor from their health, and almost half of those had at least 2, not just 1. And it's the usual players: lung disease, which we'll talk about, but also heart, liver, kidney, diabetes, etc. moving on. Skip this slide because I'm going to come back to it during the lung disease part of the presentation. This basically just shows that if you have a pre-existing condition in blue, you have a greater risk of being hospitalized than not. Not too much in contrast with common sense. And then on the next slide, outbreaks have been a significant source of cases, whether they be in a long-term care, a correctional facility, or a work site, or a healthcare setting. We've had them all over the map, and the bar graphs on the right show you that. We've had a couple of childcare facilities, but they're very modest outbreaks, one adult and one child, confined to one room, and the whole place didn't have to close down. And considering how much has gone on in childcare, this is a success story. Same as our correctional facilities. That's a success story. We've kept them amazingly free of virus, and occasionally when we find it, we're able to isolate it out. It's almost always from a staff member who unwittingly has it because they represent the communities they come from. And then the last slide in this section is the reality that outbreaks do lead to more of the deaths. And you can see that pictorially represented on the right-hand side of these Venn diagrams. So let me move on to talking about reversible and irreversible lung disease and the impact of COVID, which I'll preface with, I'm going to give you as much data as we have because there isn't abundant data, but there's enough to make some conclusions. So starting with asthma and just looking at it as a disease by itself, forgetting about COVID, we have a lot of asthma in the state, which is why I know OneCare is very interested in looking at this. 5th highest rate in the nation. Looking at adult versus child, those rates are rather high as well, the 18% and the 12% for lifetime. But even the current 12% versus 7% are high. And they actually add up to 70,000+ Vermonters. So not a trivial part of our population. If you can move to the next slide, while asthma prevalence doesn't differ significantly by race or by age, clearly there's a significant difference, female, almost double the rate in male for prevalence. On the next slide, getting into health equity a little bit and healthcare disparities, these are significant differences. So if you actually don't have a high school diploma, or you have an income that's close to the federal poverty level, your rate of asthma is significantly higher than people who have more education or more income. And it's approximately twice that. That's pretty profound, if you ask me. On the next slide, just a little bit of a summation of facts that hopefully everybody's already aware of. But people in Vermont with lung disease, forgetting COVID again right now, basically have poorer health, more limitations in their activity, more concomitant chronic disease than people in Vermont who don't have lung disease. And chronic lower respiratory diseases of all sorts, including COPD and asthma, have been the 3rd leading cause of death since 2005 in our state. And the mortality rate due to an underlying cause of asthma has been twice the US rate, according to Vermont Vital Records. Next slide. So obviously when we start talking about COVID, whether you have lung disease or not, you obviously can get pneumonia. And clearly the inflammatory response with this disease is so dramatic that in itself can be a significant illness. But the other part of this, of course, is we're seeing a lot of evidence, and by we, I mean the scientific community, not Vermont, regarding fibrosis and what the inflammatory response culminates in with this particular virus. And we need to learn more about that. But what we're learning is not pleasant at all. Even for people who didn't think they had much in the way of symptoms or much of an aggressive illness as they get followed over time. If we go to the next slide, clearly the prevalence of lung disease in people with COVID versus other Vermont adults is actually no different, which is quite interesting compared to something like cardiovascular disease where there seemed to be an excess. I don't have an explanation for this, but I present it to you. And in the next slide, we talk about underlying medical conditions that put people at risk for severe illness. And clearly, with COPD, we have strong evidence that there's a substantial impact from COVID. Unfortunately, or fortunately, maybe we should look at it that way, from asthma, the evidence is mixed and not as compelling. So moving to the next slide, we're willing to say that there might be a higher risk of getting very ill from COVID if you have moderate to severe asthma, but there clearly is an increased risk if you have COPD. This is an important point because as we reopen the schools, lots of people, teachers, staff, you name it, even parents of kids with asthma, are all worried that sending themselves or their kids to school because of an underlying diagnosis of asthma is going to be do them in, and they're going to really suffer because of that. Unfortunately, our data in Vermont isn't supportive of that at this time. But the COPD data is much more compelling. If you could move on to the next slide, we talk a little bit more about the asthma in a more granular way, if you will. I'll draw your attention to the Northwestern Medicine study of 1,500 patients over 10 hospitals. They did not find a higher rate of hospitalization among those with asthma compared to those without, though again, there was a disparity looking at the more ethnically diverse and racially diverse populations. A Harvard study looked at asthma phenotypes and found the higher risk of severe COVID was driven by an increased risk among those with non-allergic asthma. If some of you aren't familiar with the angiotensin converting enzyme receptor, ACE2 receptor, that's become an important topic. The reason it's become important has to do with medicines people are on for hypertension, but forgetting that, that seems to be the entry portal for the virus into the body, if you will, into the regions of the body where it causes havoc. So the expression of that receptor is lower in allergic asthma, which actually could be protective, if you will, for viral infection, which is an interesting sidelight. I wouldn't consider that a definitive finding, but that's conjectured at this point. And then this propensity to wondering about taking people off of steroids so they might be at less risk if they have asthma. Probably not something I would recommend doing based on everything that we've said thus far. And keeping their asthma management as in sync as possible is probably more important. Going to the next slide, COVID-19 and COPD will lead you through a little bit more about why we're more compelled about COPD. Certainly, there's a high-risk disease for readmission to the hospital. Lots have been done to try to enhance the care of these patients and make it less complex in a pandemic where you don't want them traveling to healthcare settings all the time, et cetera. So if there's anybody who we want to stay at home more than others, it's people who have severe COPD. So there have been issues about waiving provider visits for the requirements for home oxygen. The CARES Act actually requires insurers to cover a 90-day oxygen supply. A whole host of pulmonary-directed foundations and expert guideline-setting organizations have released guidelines about mask wearing and messaging for patients with these conditions. And then there's a lung helpline as well. Now, there are a lot of issues and concerns for those with respiratory disease that are on the next slide. There's a differential impact in COVID times. So obviously, minimizing exposures to cleaning products and protocols, well, these are all aggressive in COVID. So there's probably an increase in risk for those who have respiratory disease with some of these more aggressive cleaning protocols. We all know that most people with asthma, we think, can do well with a mask, but people with FEV1 over FVCs that are quite low with COPD are probably going to have trouble. There's a whole host of issues regarding location and types of environmental exposures and the triggers that might precipitate decompensation. There's the issue of our children potential vectors, and then their teachers who might have underlying respiratory disease get worse because they were in the classroom in the first place. I don't want to say yes to that one, but we have to validate the concern that many of these teachers have because we can't be definitive here. And then this whole stress that's related to living in a pandemic, the stress of being socially isolated because we've asked you to stay at home, can only compound the difficulty of those who already have a less active existence because they have respiratory disease. On the next slide, there are some parts of COVID times that can actually benefit patients with respiratory disease because obviously if they're doing all the behaviors we want, they might actually have less exposure to viruses and bacterial infections. If we could follow Australia's path, and I'm hopeful we can, Australia had a great flu season this year, was not a super aggressive one. And one of the hypotheses, of course, is if you're doing all the right things to prevent yourself from getting COVID, well, why wouldn't that protect you from another viral infection like the flu? So maybe that's happening because people are just less congregated together. So a side benefit, if you will. There are clearly new opportunities and emphasis on outdoor activities for physical fitness and quality of life. Air quality is being paid more and more attention to, and HEPA systems and increased recirculation. So perhaps less dust. And then if you're outside, less diesel particulates from vehicle traffic, because at least until recently, there has been less vehicular traffic. And then obviously, if you're not in the places where you're usually going to have the triggers from people or from the environment, you're going to have a better time. But as we reopen all sectors, that becomes less and less able. The next slide just shows a little bit about maintaining asthma and COPD management. A call out to telemedicine that's been so successful and should continue to be successful in the management of patients with these illnesses, because unless they're in the midst of a decompensation or an exacerbation, plenty of information can be gleaned from a telemedicine visit, including for those who check it, their own peak flows and things of that sort. Ensuring patients have medication. We talked about oxygen before, but obviously there have been ways to get people medication safely and without having them put themselves at risk. We've talked about less environmental and trigger exposures, but there are also ways to address this by using cleaning products that would still work in the COVID environment, but that might be fragrance-free and less toxic. And then finally, I won't talk as much about the disease self-management programs. That's something I'm sure you're going to want to talk about a lot, but there's a little less of the home visiting components to many of them. So there needs to be ways to deliver that curriculum, if you will, in a safe manner. And then addressing this entity that we're calling COVID-19 related stress. which certainly can be a new potential trigger. And then the last slide in this section is best practices that support patient care. We never stop talking about smoking cessation, so why not now? We never stop talking about secondhand smoke exposure. We always talk in terms of care management about an asthma action plan or a COPD action plan. None of these things are obviously things that should cease in COVID time. They should actually increase. And then the issue of triggers, obviously. And then the next slide is just, again, quitting smoking. You can skip that. And just this last thing is a little more COVID relevant, reinforcing the hand washing for good hygiene, reinforcing physical distancing, making sure that you don't just assume a mask is not going to be working for the person, but trying to address that challenge and see if it can be balanced with breathing difficulties, especially if the person's getting out or if they have people coming into an indoor environment. And then God knows, of course, the vaccination initiatives, which you'll be seeing more and more of from a public health messaging standpoint. I'd like to close the presentation with just a few slides on health equity, because this really is, I think, a critical part of this exercise. So health equity, for those who don't commonly define it, has to do with the opportunity to be healthy. Not just that you can be healthy, but you have the same fair and just opportunity to be healthy. And usually when you don't have that opportunity, it's because of systemic inequalities. And often those are associated with race, gender, ethnicity, etc. All of the usual players when it comes to where disparities show up. So moving to the next slide, everybody understands the social determinants of health. Basically, the conditions we find ourselves living in that kind of combine our own genetic potential with the environment, whether it's the physical environment, the economic or social environment. And it's all the usual players: housing, poverty, transportation, food security, you name it. And the WHO recognizes 10 factors that affect health and life expectancy, and they're listed for you at the bottom of the slide. I won't read all 10. They're, again, pretty commonsensical. If we look at the next slide, this sort of summarizes in one slide the fact that we have issues of wealth and traditional injustice in that arena of who enjoys wealth, who doesn't. We have the built environment, which is not just housing, but it's transportation. It's the opportunity to be able to walk safely from one, etc. It's the zip code you live in that determines your life expectancy, not other things. And we have, of course, education. We have food security, all built into one slide. And determinant of the health outcomes, whether they be morbidity, mortality, cost to the healthcare system, etc. On the next slide, showing you the social determinants in action. This is a slide we talked about earlier, how we can look at prevalence of asthma and see that there's a close tie-in between one's educational status and one's economic status. So I won't have to repeat that for you. And then moving to COVID and health disparities, one of the things that we've learned the hard way, and we learned it in Vermont, but we've learned it all around the country and the world, is the racial disparities. And frankly, we were embarrassed about it in Vermont because we weren't collecting sufficient data early on, and we didn't have enough data to come to the right conclusions. And it wasn't intentional, it's just that people had so many questions they were asking to get data that race didn't become regularly integrated into that portfolio of questions. Now we're close to 100% asking, and we can clearly say that though Blacks and African Americans are a minority of the population in Vermont, look at the tenfold rate of having COVID that they have compared to whites. It's absolutely dramatic. As I said before, because our numbers are small, hospitalizations and deaths do not show that kind of a disparity, but that's just because we've hardly had hospitalizations or death occurring. And then if you want to look at it from an ethnic disparity point of view, the next slide shows that though Hispanic Vermonters are actually a very small portion of the population, they have a twofold higher rate of developing COVID, becoming a case, than someone who's non-Hispanic. Those who see the next slide will either go, oh God, he's still showing that slide, because it's complicated, but it really isn't. If you just clump the three purple vertical bars on the right into sort of what we deal with in healthcare all the time, and how we deal with health issues, if you will, and then you look at the two middle, which is called going midstream from the downstream approach. Those are all the conditions we find ourselves living in, which is code word for social determinants of health. And then you go to the two left columns. Those are the places where health equity plays a role, and the traditional social and institutional injustices that parts of our population have traditionally suffered from. That's going upstream. So that gives you the sort of context. And then the next slide tells you that essentially it sort of summarizes what I've said, that we have health inequities across all aspects of public health. Some conditions, like respiratory conditions, have been exacerbated by the pandemic. And if you were using a health equity lens, you would ask the kinds of questions like, why are different populations impacted more than others? What are the systemic causes that contribute to these inequities? And are there power imbalances? And what is public health's role? And that's illustrated on the next slide, applying a health equity lens, looking at poverty as the tragedy here. So low, medium, and high poverty. And then look at this. This is asthma dealing with triggering events, whether the trigger is cockroaches, other vermin, homes with maintenance deficiencies, or mold. Those are the orders of the column, or secondhand smoke. But notice how they stay in the same order, whether you're low, medium, or high poverty, but they also get dramatically elevated in the highest poverty group. That's why a program like the Camden Coalition in Camden, New Jersey was so successful, because they abandoned the usual reasoning for why somebody with asthma was doing poorly, like they weren't complying with their inhaler or they didn't know how to use their inhaler. They found out that was not the reason. The reason was the building they lived in. And they had a massive campaign to fix some of these things that are on the slide here, and dramatically improved the condition of asthma in Camden, New Jersey. So if they can do it there, you can do it anywhere, for sure. And then the final two slides are just the fact we have a health equity and community engagement team that really learned a lot from Winooski, is carrying on in that tradition to really partner with organizations that serve BIPOC communities, really looking at the priority populations that are disproportionately impacted by the pandemic, and doing a lot of culturally appropriate planning, workforce development, etc. And the final slide just shows how we've used some of our coronavirus relief funds to work in a health equity range. So what we've done is we're funding Spectrum Youth Family Services, which everybody knows about, and they care for a lot of our New American community. We're funding some of the UVM Extension, who are involved intimately with the migrant worker community. And in Southern Vermont, in at least 2 counties, we're funding the United Ways, who deal with racial and social justice organizations and disabled and older Vermonters. So again, these groups that suffer from disparities and where health equity really becomes a dominant theme. So I will stop there, and I don't know, Norm, if we do have time before 3 to have questions. I'm certainly available, but I don't want to interrupt your whole schedule.
Well, as you're speaking, Mark, I've been padding the chat box with a few questions. So You could, start at the bottom and work towards the top, whatever strikes your fancy.
All right, let me figure out how to, here it is, chat box. Okay. Well, I'm already at the bottom, so let's see. Will the slides be available? Well, you've got them, so you can disseminate them as you'd like. Is there any objective criteria we can use when asthmatics request doctor's note to be excused from mask wearing? So, that's a really challenging clinical decision. And we've tried to help clinicians with that. We have a one-pager that we put out to try to help them through the medical society. I wish there was an objective criteria. There really isn't. And so some of it's going to have to rely on the ability or inability of a person with asthma to feel like they can wear a mask. But our data would support asthmatics being able to do that as long as they're well managed and on their medications, et cetera, and not exerting themselves strenuously, versus a COPD patient where I think the answer is much more black and white, if you will. How are we going to clinically tell the difference from the common cold and COVID? Is a liberal testing approach the way to go? Yeah, that's a challenge. So I would say that a common cold still is a common cold, but if the prevalence of the disease in Vermont has increased from a 2% positivity rate to a 8% or 10%, then we ought to be very, very erring on the side of over-testing and taking people who have minor symptoms, but that could be COVID symptoms, and going to town with them. I think if we have colds at a time when we're not seeing much COVID, we could use our clinical judgment appropriately. I think even more importantly, we're looking for this triple test where you can do the flu, RSV, and COVID at the same time. And a lot of the platforms we have, like the Cepheid platform that UVM has and that we're sending to a number of hospitals, are going to have that platform. That test is supposed to be out in the next month or so. And I think that's going to be the go-to test, because it's equally confusing to understand if somebody's got the flu or somebody's got COVID. At least the flu, we can give them something. Whereas COVID, it's kind of like supportive care right now, unless they're in the hospital, and then we know what to do for them. I'm hoping not to be answering these questions super superficially, but I want to try to get to as many of them as I can. So let me see where we're going here. Any special recommendations for oral steroid therapy in the outpatient setting for COPD compared to standard care for those with suspected COVID? Yeah, I don't know the answer to that one, but boy, because dexamethasone worked so well in the trials of people who were sick in the hospital, clearly we might go to oral steroids quicker in people with COPD than we might have before if they're having any trouble whatsoever. If I start out with fibrosis and am immune suppressed, what are my chances for survival? I can't give you the number, but boy, that's a horrible scenario, isn't it? Clearly, that person needs to be stay home, stay safe, and don't have their grandchild visit, don't have anything happen, especially during the fall and winter months. Are our high rates of asthma correlated to excellent availability of primary care in diagnosing the condition compared to other states? That's a really good question. Do you want me to answer yes or no? Because I could answer yes, because we all want to say we're great. But I could also say no, it's just the way it is. We have more of that in Vermont. I'm going to ask my team in chronic disease if they can help me answer that, because I don't want to just superficially say, I don't think so, if there is a more definitive answer. So let me find that out for you. The current estimate of false negative PCR testing is 5%, but I would take that with a grain of salt, because everything we use to test, even on PCR, which is our gold standard, was approved with an EUA, an emergency use authorization. And the bar for getting an EUA is very different than the bar would be for what you would select as a test. And most of the platforms that went through the EUA process, they didn't have to show a lot. They had to show a good accuracy rate when you had known COVID positive and COVID negative specimens, and a comparison was made of how accurate your machine was compared to those gold standards. In clinical medicine, what we really want to know is when we apply these tests in a large population and in our practice, using all those principles of what is the pre-test probability of the disease, and then get a test result and find out the post-test probability, what is the prevalence of the condition, those things lead to a whole different set of numbers when you come out to understanding the positive and negative predictive values of your test. And we just don't have that in this pandemic right now. All we have is that more initial data, noting that these tests are very good at picking up exquisitely low numbers of viral particles. But that's not the answer we want when we're practicing medicine always. I saw there were some things at the bottom that were added in.
Right.
How confident are you in Vermont's ability to maintain a low positivity rate in the fall and winter? You know, all bets are off. I'd like to maintain my confidence in Vermont because it's gotten us to where we are. And the schools and the colleges are reopening rather smoothly right now. But what does the fall and winter represent? It does represent flu season. It does represent people getting more colds. It does represent people going indoors for all the right reasons, and potentially could represent them congregating more indoors for the wrong reasons. So all bets are off. I do have a lot of faith. It's nice to start with a low positivity rate as we get into the fall. That puts us at a distinct advantage. But if you look at the state of Maine, all it takes is one wedding in a place like Millinocket, of all places, and all of a sudden you've got a county that went from green to yellow. You've got York County that went to red, where a lot of the people came from who went to that. And you've got parts of New Hampshire that were affected. Then you had a correctional facility and a long-term care, and people actually died. So, you know, it only takes one major event like that, and it can change the equation. So until we get the vaccine and until we can really manage this well, we're stuck in this kind of fragile state, if you will. Shall I stop, Norm? Because I think it's 3 o'clock and we've covered a lot.
Mark, you've exceeded our expectations, but I was confident that that would be the case. So thank you very, very much. For those of you on the phone, between now and 3:30, we're going to be having a for our collaborative. So if you are amongst the practices that are going to be participating in the Asthma COPD Quality Improvement Collaborative, please stay on the line. We will be introducing some speakers to run through a slide deck to acquaint you with the aspects of the collaborative. For those others, you can sign off now. You can certainly stay on and see what we're doing between 3 and 3:30 as well. Mark, again, thank you so much, and we'll transition now to our next meeting.
Thank you all for being so attentive. And if I could just ask, if you don't have a formal evaluation form or something, connect with Norm, because I'm going to have to give talks like this a lot in the near future, I think. And I want your clear, honest feedback so I can actually do it well and do it right. Because needless to say, I don't have time these days to do anything. And I got this together rather quickly, but I'd much appreciate your feedback. Thanks, everybody, and goodbye.
Thank you, Mark. So, Tanya, I believe that when people complete their evaluation,